Okay, so hi everybody. My name's Nigel. I'm part of the Learning, Education and Development team at CVS, and welcome to this next instalment of the webinar series from our referrals colleagues. I'm delighted to say that we're joined again today by Javier from Lumbury Park Veterinary Specialists, and this is actually the second part on immunomodulatory therapy. We did the first part, I think it was it last month, Javier? I'm losing track of.
Yeah, it was about 6 weeks ago, I think.
About 6 weeks ago, where we looked at and discussed steroids. And in this one, we're going to discuss second-line immunosuppressive agents. Just before I hand over, we should have some time at the end for some questions. So if you do have any questions, if you go to the Q&A button in Zoom, click on that, it'll open the box. And then if you type your questions in there, and then I'll come back on at the end and we can put those to Javier. We're also recording this session, so you'll be able to watch this back in your own time. We'll release that on Knowledge Hub over the next few days. And the previous recording is already there, so you can go back and watch the first session as well. So great. So I'll hand over to Javier.
Excellent. Thanks a lot, Nigel. Thanks a lot for the presentation and for organizing this. As you well said, yes, this is indeed one of the two talks I've been doing recently. The first one was basically focusing on steroids and indications, contraindications of a steroid therapy. However, today I would like to talk a bit more about second-line immunosuppressive agents, because I believe some of you may be using them in practice. It's something that we definitely consider quite a lot here in the referral setting. And I just want to present a few things about these drugs. So that's it. As we said, this is one of the two talks. And why talking about treatment for immune-mediated disorders? Because these conditions are extremely common in practice. Okay, we have all probably have come across IMPA, IMHA, chronic hepatitis, chronic enteropathies, SRMA, MO, and atopic dermatitis. And so these are very, very common. Most of them are treated with steroids alone, but there will be some cases in which considering a second-line immunosuppressive agent may be a good idea, okay, to reduce side effects of steroids and so on, that we will discuss a little bit later. So as I have mentioned, the third choice and the first line treatment when wanting to immunosuppress a patient is a steroid. We are probably familiar with prednisolone, dexamethasone, methylprednisolone. And why do we use these drugs? We use these because they do downregulate the immune response. Therefore, turning down the immune system, we expect to see a reduction in inflammation and a reduction in desactivation or abnormal activation of the immune system. Steroids will not only reduce antibody production, lymphocyte synthesis, but as I said, they will also inactivate some very important cells such as macrophages. And everything is going to result in a deactivation of the immune system itself. However, although, as I said, steroids are first-line treatment, I suspect some of you are already considering second-line immunosuppressive agents. This can be used alone as a standalone treatment or can be used together with the steroids, which is probably the most common practice these days. Atopica, which is cyclosporine, is probably the most common, the most popular one, but azathioprine, chlorambucil, leflunomide, mycophenolate, are other drugs that we will be talking about in a few minutes, which are getting quite important in practice, and I think is definitely relevant. We are familiar with the drugs, both because you may use them in general practice, but also because we often refer cases back to you after diagnosis with treatment, and treatment considerations and so are important. So hopefully this talk won't be too intense and will help clarify a few things about these drugs. When we talk about immunosuppression, which either steroids alone or steroids combined with a second-line immunosuppressive agent, the aim is always the same, is reducing the activation and efficacy of the immune system. There are many protocols described in the literature. If we are to open Ettinger or the BSA-VA manual, we will find some protocols. But I think it's very important that we always individualize these protocols. Okay, there is no A regime we can just follow. This needs to be adjusted to the patient, their body weight, their breed, concurrent disease, severity of disease, previous exposure to steroids. And just a clear example is what happens if a diabetic patient has an immune-mediated disorder. Are we going to give a steroid? Probably not. And here's when using a second-line immunosuppressive agent is important to consider. The goal for immunosuppression is always the same. It's using the minimally effective dose. And this is especially important for the steroids, all right? Because long-term side effects of steroids are common. We have all probably seen them and can be very dramatic. And here, once again, if we combine it with a second-line immunosuppressive agent, we may see better results. So let's start talking about these drugs. I will just give a brief definition of second-line immunosuppressive agent, but then we'll talk about the aims of these drugs. Just briefly, I'm going to go through the mechanism of action, so some basic pharmacology, and then we'll talk about each different drug, indications, contraindications, and side effects. It's quite dense, and we could talk for hours about this, but hopefully I have summarized the most important and the most relevant things for us as vets in practice. Just the definition, a second-line immunosuppressive agent is a drug that will downregulate the body's immune response, as we can imagine, which is generally used alongside steroids, so alongside the first-line treatment, but occasionally they can also be used as a standalone treatment, for example, in diabetic patients and so. What are the aims? So three aims here. One is to produce a better outcome. So the whole point of introducing a second-line immunosuppressive agent is to speed up the recovery process of these patients and kind of put the autoimmune disease or the immune-mediated disease in remission quicker. It will also hopefully help speeding up steroid tapering. So we may end seeing less side effects of the steroids because we have combined it with another drug. And in some cases, as I have already mentioned a few times, it will help replace steroid treatment. Let's start with the first one. To produce a better outcome. As I said, and I put this one as the first aim or goal of these drugs, I must say that most of the things I'm going to be saying are clinical expertise and something that we see in practice, something that we believe work, but at the same time, we don't have much evidence-based medicine when it comes to using second-line immunosuppressive agents. Okay, so there is some research, and I'm going to go through a few papers just in a second, but at the same time, we don't know enough about these drugs. We still use them because evidence-based medicine is not all about research, it's also about clinical expertise and what the client or the patient wants. But again, there is a lot to learn and a lot to research. Here, just a few papers, just to introduce a little bit the topic. We have here a paper which is focusing on immune-mediated hemolytic anemia, which is, as you probably know, one of the most common immune-mediated diseases affecting small animals. And here, this paper shows that's a relatively old paper already that show that combining steroids and azathioprine can actually improve both the short-term and long-term survival with dogs with IMHA. Is this because combining both drugs will increase our immunosuppression? Possibly. Mycophenolate is another drug that we use, and there are papers in which they show the effect of the combination of steroids and mycophenolate. It has also been used as a single agent, so it has the potential to be used alone as well to treat some autoimmune diseases. Here, just kind of the same, mycophenolate used in cats. It seems to be effective treating primary immune-mediated hemolytic anemia. Cyclosporine, which I believe everyone uses in practice for skin problems, and so had some evidence that it works quite well treating immune-mediated polyarthropathies. However, as I was saying, although there are some studies out there proving or describing the efficacy of these treatments, generally they are relatively small studies. So we still need to learn more about these drugs to use them more comfortably in practice. Kind of the same here, cyclosporine, there is some evidence that as a single agent can also help manage enteropathies, especially if they are refractory to steroids. I don't worry too much about all these papers because I'm kind of gonna describe them all later on when we go drug by drug. The second aim is to speed up steroid tapering, and this is key and super important in large breed dogs. As you know, large breed dogs are very sensitive to steroids. We know that giving them exactly the same dose as we give to a smaller breed dog, let's say 2 mg per kg of pred, they will get higher blood concentration of the steroid, meaning that we will probably see more side effects. And this is important. This is important because sometimes the side effects of the steroids in these patients will be even more concerning than the clinical signs caused by the disease itself. And the owner may struggle with that. Not only the dog, but the owner. Because like, God, you're treating my dog with a drug that is causing more side effects than the disease itself. And in these patients is where I would strongly consider adding the second-line immunosuppressive agent, because hopefully that's going to allow a quicker reduction in our steroids. I talked about this a few weeks ago when during my talk about the steroids, and it is important here that we do these large breed dogs using the body surface area, the BSA, rather than the body weight, because it does give a far more accurate dosing, and the advice these days is that we use meter square. And for prednisolone, what would be an equivalent to 2 mg per kg, it's generally a 40 milligram per meter square. And the third aim of using a second-line immunosuppressive agent is to replace steroid treatment, okay? Either to avoid complications associated with the steroids or when steroids are actually contraindicated. And when are steroids contraindicated? So in a few conditions, I would say the most important one is diabetes. You have all probably seen diabetic patients, and you know that cats are especially predisposed to develop diabetes while on steroids. We know that about 10% of cats will develop diabetes as a consequence of a steroid treatment because they just develop a very quick insulin resistance. In dogs, it is a problem as well, but especially in dogs that were already pre-diabetic. And what I actually learned preparing these dogs is that in humans is actually a very big problem. In 20% of patients going on steroids will develop diabetes. So it's something to take into consideration. When does this diabetes happen in cats? It generally happens during the first 3 months of treatment. And this is probably because it's dose dependent. As you know, with the steroids, what we normally do, we start high and then we taper. So at higher doses, these cats develop more insulin resistance and therefore diabetes. And something that you can easily do in practice before you start a cat on steroids, do a quick urinalysis. Is there glucosuria there? You can probably still use the steroids, but then just keep a very close eye on these cats because we know there is a link, there is a correlation. If the cats are glucosuric prior to starting steroid treatment, then they are more predisposed to develop diabetes. So in these dogs, these cats, definitely consider a second-line agent. And in this case, atopic or cyclosporin would be our drug of choice. It's not an ideal drug, and it had some disadvantages, and both in humans and dogs, we see that it does increase the risk of hyperglycemia. However, this hasn't been described in cats, which is positive, probably is because no one has looked into it, but it hasn't been described in cats. And the other disadvantage of atopic is that it's just extremely expensive. Maybe in a cat and a small dog, it's not as bad, but it's generally quite expensive. But these days, we believe it's the best alternative to steroids in diabetic patients. Another consideration here, and equally important, is in those cases in which we do have severe muscle atrophy, either because of steroids or because of a disease process such as polymyositis or GI disease, or dogs with very reduced mobility. If we start a dog with polymyositis on a higher dose of steroids, we may treat the underlying autoimmune disease, but at the same time, we will contribute to this increased protein catabolism that will lead into muscle wastage, so muscle atrophy. That will certainly affect the patient's quality of life. So when you are treating an autoimmune polymyositis, do consider a second-line immunosuppressive agent. We certainly do. I guess through medicine, we don't see many polymyositis, but my colleagues from the neurology department, they generally start these dogs on a relatively lower dose of PrEP and then start second-line immunosuppressive agent straight away. Another disease to consider when it comes to using second-line immunosuppressive agents is classic dogs with steroid-induced GI ulceration or bleeding. We know that GI bleeding happens very commonly in dogs with the steroids. However, it's often subclinical, and we have no idea they are internally bleeding until they become clinical. Some studies have shown that actually dogs on steroids are 7 times, or the odds of having ulcers are 7 times higher in dogs on receiving prednisolone compared to placebo. Therefore, especially if we have a dog that is on treatment for, let's say, immune-mediated polyarthritis, and the owner documents or noticed malign at home, then do consider either tapering the steroids, and if you feel that the patient will require more immunosuppression, add a second-line immunosuppressive agent as well. Mechanism of actions, we could talk for hours about these. I have hopefully summarized the main drugs here in this slide. There are 4 main mechanisms of actions here. Cytotoxic drugs such as chlorambucil, then drugs that will reduce the function of T cells, cyclosporin and tacrolimus, that you are probably also familiar with, used topically to treat keratoconjunctivitis sicca. Some drugs will affect DNA synthesis, and these does include azathioprine, mycophenolate, leflunomide, and cytarabine as well. And then I have also included here the polyclonal antibodies. These are not commonly used in practice at all. These are very expensive, human medication, very difficult to get hold of, but they can definitely be used. They can definitely be used as well in an emergency setting where you really want to turn down the immune system. These would be more for IMHAs, ITPs, when patients are spontaneous or bleeding. We don't really know much about the use of IVIGs in small animals, but anecdotally we have used it. Sometimes we have positive response, sometimes not so positive, but it's something that can definitely be used and is a possibility, especially for those patients that are quite refractory to steroids or other types of immune suppressive agents. Why is it important to know a little bit about pharmacology? It is actually important because imagine that we have a dog on steroids and we then add cyclosporin. We see no response whatsoever. Will you then start this dog on a tacrolimus? Probably not. Probably that would actually be contraindicated. You need to use a drug with a different mechanism of action. So then consider azathioprine, mycophenolate, because it may work better. Okay, is there evidence for this? I'm not quite sure there is, but it does make sense pharmacologically that you use a drug with a different mechanism of action. So that's why it's important to have a bit of an idea on how these drugs work on our patients. Let's now talk about the drugs. Unfortunately, we don't have time to talk about all drugs. I'm going to talk about cyclosporine, azathioprine, mycophenolate, and levodopa because these are the most commonly used in practice, the ones that you have probably seen either because you use them in practice or because you see patients referred from us with that go home with steroids and one of these drugs. So let's start with cyclosporine. Cyclosporine does reduce the cell activity, as I have just mentioned. It is licensed to treat a few conditions, especially skin atopy, such as canine atopic dermatitis, but also in cats, but is also used for other immune-mediated disorders. We normally use it PO, don't we? There are some topical creams as well with cyclosporine. There is an injectable form. I have never used it. I have never seen it myself, but I know there is an injectable form. It's something that is available in the States, could potentially be available in the UK, but not to my knowledge. And as I said, we don't use it. We normally go for the oral dosing. Different doses have been described, and if you look at the BSA formulary, what you will find is that to treat immune-mediated disorders such as IMHA, then 5 mg/kg PO/BID is kind of the standard dose. Then for skin problems, liver, when I say liver, I mean chronic idiopathic hepatitis or chronic enteropathies when it comes to intestines, then they tend to use it at a lower dose, or the evidence support that lower doses are okay. And cats seem to have a higher requirement, therefore they need a higher dose of Atopica or Cyclobans or whatever brand you use. The dose will, however, need to be adjusted up or down depending on whatever you have on the shelf, because I think Atopica was made at 25 and the 50 milligram, therefore you will need to adjust the dose depending on what's available. There is a liquid form, which is good for cats and for small dogs, but I don't think it would be financially possible to dose a large dog with liquid formulations. Technically speaking, we don't need to taper cyclosporine, and this applies to all other second-line immunosuppressive agents. With the steroids, we definitely need to taper, and I don't need to explain why. However, with second lines, we don't have evidence that tapering makes any difference. Sometimes a gradual dose reduction can help the owners, or in the sense that if the patient is going to relapse, if you kind of gradually reduce the dose, you may be able to spot when the patient is relapsing. But again, does it make a difference? We don't know, and we don't tend to taper second-line immunosuppressive agents. One of the downsides of cyclosporine is that once ingested, it will achieve a very variable blood concentration, and this makes adjusting the dose quite difficult, because at a set dose, some patients may be completely immunosuppressed, and others may have no effect of the cyclosporine or whatsoever. And just for you guys to know, there are a couple of assays available, mainly the States, nothing here in Europe or the UK. One of them looks at the blood drug levels, and the other one does from blood that you have taken from your dog on cyclosporine. They will do an in vitro assay, and they will establish whether there is enough cytokine suppression. So these are tests, as I said, they are feasible, they are available. However, the logistics are not very easy, aren't they? Because you need to send the sample to the States, and results take a few days, few weeks. So it's not easy, but it's possible, and it's something that you may want to consider in relatively stable patients in which you want to consider a dose reduction or a dose increase, and you want to have some reassurance, and you want to make sure that you are making the right decision, then do consider this. Okay, if you go to the Mississippi State University College website, they have a lot of information, very useful information that can help with the logistics as well. Having said that, however, does this correlate with a clinical progress? Do we know whether if there is a strong cytokine suppression in vitro, does that correlate with a better outcome? I don't think we know these days. I know there have been some recent publications about this, but I don't know whether it actually makes a difference for our patient. We should learn with time, hopefully, but definitely something to consider and something that we request on occasion. Cyclosporine may work quicker than other second-line immunosuppressive agents. So if you need something quick, if you need the patient to be immunosuppressed quickly, then probably will be the drug of choice. We know in healthy dogs that after 24 hours of giving cyclosporine, there will be a marked decreased production of the cytokines. However, very interesting here, the same studies performed in dogs with IMHA show something a little bit different. So it could well be that healthy dogs will respond very quickly to cyclosporine, so their cytokine production will reduce quickly. However, if we use the same drug at the same dose in dogs with an autoimmune disease or with an immune-mediated disease, the cytokine suppression may not be as efficient, may not be as effective. And this could well be because they do produce less interleukin-2, which is the target of the cyclosporine. All right, so it has the potential to work quicker, but if your patient is suffering from an autoimmune disease, it may not work as quick as if it was a healthy dog or a healthy cat. We estimate that cyclosporine will work in days to 1-2 weeks. Considerations and side effects. So not many, really, and the ones that I'm going to describe are relatively minor and self-limiting. So GI upset, I'd say, is probably the most common clinical sign observed in dogs or cats receiving cyclosporine. Self-limiting vomiting, diarrhea, nausea, inappetence. It happens in up to 30% of the cases, which is significant, but as I said, with a few changes, they are generally self-limiting. What can we do to reduce the incidence of the GI side effects? Few things. We know that giving the drug at least 1 hour before or 2 hours after a meal may actually reduce nausea. Some people may give it with a very small meal to facilitate tablet administration or with a treat. I think that should be fine. Okay. However, it should technically be given on an empty stomach to reduce GI upset. And another thing that is very interesting, and I always do because anecdotally, I think it does make a difference, is freezing the tablets. All right. We should always recommend that patients receiving cyclosporine, when they receive the tablets, these have been frozen for at least 1 hour prior to administration. This does seem to reduce GI side effects. Why? I'm afraid I have no idea, but it does make a difference. It does make a difference. I forgot to mention here, with the liquid formulation, is not as easy. I normally recommend they keep it in the fridge. Obviously, that's not frozen. Does it make a difference? I don't know. It kind of makes sense that the cooler it is, the better, but I don't know. This does apply to tablets, but I'm not quite sure what the recommendation is when it comes to liquid formulations. Another thing that some of you may have seen, I have never seen it, I don't think, is gingival hyperplasia. This is another relatively common side effect of cyclosporine. It can happen generally when you stop the treatment or when you reduce the dose, it goes away. I think some people treat it with azathioprine, which is another second-line immunosuppressive agent that we're going to talk in a second. But it seems it's a relatively common side effect that you may see, and some breeds are, I think, predisposed to develop the gingival hyperplasia. I think is Alaskan Malamutes and Huskies and breeds like this. Then another couple of things to mention here, relatively less relevant because they are quite rare. Liver toxicity has been described. It's not dose dependent, it's just an idiosyncratic reaction. Some people believe that cyclosporine will increase platelet function. Therefore, these patients will be predisposed to form clots. And as we discussed earlier, there are some papers suggesting that cyclosporine will affect your glucose metabolism. Therefore, it's a consideration for diabetic and pre-diabetic patients. But these are relatively uncommon. Definitely, the most common one is the GI upset. And have you ever come across this? Probably so. There were a time 2004 and 2015, there were a few papers published there saying that cyclosporine can cause toxoplasma. However, I wouldn't word it that way. I think these cats probably had toxoplasma already. That was subclinical, that was just silent, and once they were immune suppressed, then they developed clinical toxoplasmosis. So probably these would apply to all types of immunosuppressive drugs, right? If you immunosuppress a patient with a subclinical silent infectious disease, when they are immunosuppressed, the disease will become clinical. So I think that's what actually happens with these cats. It's not that cyclosporine will predispose cats to have toxoplasma, it's just that you are going to immunosuppress a patient with subclinical disease. The question here is, do we routinely screen all cats going on atopical or cyclosporine for toxoplasma? I don't think we do. I don't think whether that's the right or wrong thing to do, but I have certainly started cats without checking or screening for toxoplasma. But it's something to consider, and some people may want to do it, and probably that's the gold standard. So just for you to consider, and something to discuss with the owners as well, especially for those cats that are generally outdoors or those cats with obviously toxoplasma. And here, the main downside of cyclosporine. So cyclosporine is extremely expensive. It is expensive for big dogs. For small dogs and for cats, it's not the end of the world. Okay, it's something that generally clients can afford. But if you are planning to treat a 25, 30, 35 kilogram dog with cyclosporine, and if you use the recommended dose around 5 mg per kg BID, you may end with a bill of 600, 700, 800 pounds a month just for the cyclosporine. So this may be no problem for some people, for some this may be a huge problem, and you may need to explore other second-line immunosuppressive agents. Because as you can see here, leflunomide, mycophenolate can be relatively cheaper. Azathioprine is definitely not very expensive. So here I would consider other drugs that are generally cheaper. I see here mycophenolate, they put it's about 30 pounds a month. It is true that that's if we use the Celicept or the Kelicept, however people want to call it, because it's the human one. If we use the Bova, I think one, it's far more expensive, unfortunately, because it's a special formulation for dogs and for small dogs and for cats. Therefore, it's going to be definitely more expensive, by no means 30 pounds, and it could well be that we are over 400 and so, but it's definitely cheaper than cyclosporine. How should we monitor patients on cyclosporine? So we don't know. to be honest. We don't have enough information available. However, if we look at the IMHA consensus statement that does do an excellent review, if you haven't read it and you like medicine and hematology, please read the IMHA consensus statement because it's excellent. It does do an excellent literature review of all second-line immunosuppressive agents that can be used in IMHA, and does give some recommendations on how to monitor these patients. And in the case of the cyclosporine, they do recommend a serum biochemistry every 2 to 3 months. And this is just because in some dogs, as I just mentioned, it can cause hepatotoxicity. It's not a common side effect, but better be safe than sorry. So every 2 or 3 months, do a serum biochemistry for these patients. You may be doing bloods anyway to monitor disease progression or disease remission, but do include some liver values from time to time as well. So I hope this makes sense about cyclosporine. Another drug that we use as well, maybe not as much, it's very clinician dependent. Some of my senior colleagues love azathioprine, some of them really hate azathioprine, and it shows that there is no real guidelines or nothing. So everyone does a little bit whatever is more comfortable with, which is also very reasonable and very sensible. So azathioprine does not reduce lymphocyte or T cell activity. It will actually act on DNA strands and will inactivate DNA synthesis. What's extremely important with azathioprine is actually the azathioprine itself is just a pre-metabolite. It's not an active form. And you will need an enzyme called TPMT, which will be essential to activate the drug itself. And why is this relevant? This is very relevant because our cats won't have this enzyme. So cats do not have TPMT, therefore it is not safe and it's contraindicated to give cats azathioprine because they have this deficiency in this enzyme. There are reports, and it's something that we have seen as well, because cats receive azathioprine by mistake, unfortunately, and it does cause very, very severe bone marrow suppression. All right, so these cats will become very pancytopenic, which is life-threatening. All right, so we should really avoid the use of azathioprine in cats. And is it safe to use in all dogs? Not really. It's safe to use in 99% of dogs, but there are two breeds here, giant schnauzers and Alaskan Malamutes, that will also have some mutations in the TPMT enzyme. In schnauzers, they will have a lower concentration, a little bit what happened with cats. And in Alaskan Malamutes, they will actually have a higher activity of this enzyme. And these changes can definitely affect efficacy of treatment and drug and can increase drug toxicity. Therefore, if you are to use azathioprine in these dogs, or if you are to use azathioprine in a dog, is fine. But if you present one of these two, you are presenting with one of these two drugs, maybe explore other options. Better be safe than sorry again. The dose of azathioprine, or the formulary dose, is 2 mg/kg POSID. We generally taper quite quickly. So it's a drug that has a very slow onset of action, so it's by no means good in an emergency setting. It will take 2 to 3 weeks, but generally after 2 weeks of treatment, we taper to every other day. And this is probably something that you have seen when you see patients that we have diagnosed here and you see them back for follow-up, that we recommend a dose reduction or going to every other day, pretty much. Why do we do this? This is because of hepatotoxicity that I will just discuss in a sec. Azathioprine is definitely not expensive, so it's a very good option when there are financial concerns. When it comes to side effects, obviously azathioprine has side effects, and so all the others. Azathioprine can cause myelosuppression. All right, it's something that we don't see with cyclosporine, for example, but with this drug we do. It is relatively uncommon and will only happen in 8% of the cases. What is definitely more common is these patients developing poorly regenerative anemia, which is important, right? Because if you have a dog with IMHA that you are treating with steroids and azathioprine, and you see that the PCV improves, but it doesn't actually go to normal range. If the dog is on azathioprine, consider that. Is it because of the azathioprine, this persistent poorly regenerative anemia? And then you may want to reduce the dose or you may want to stop. So, but it generally just a mild anemia. And myelosuppression, as I said, will only happen in 8% of the cases. GI upset and pancreatitis can also be seen with azathioprine. Hepatotoxicity can also be seen, and here is definitely more common than with with cyclosporine. It is actually seen in about 15% of the cases, so a significant number. It is reversible, okay, so if these patients have a hepatotoxic insult because of azathioprine, it's not the end of the world. It generally then reversible, you stop or you reduce the dose and they do absolutely fine. And if it happens, the good thing is that it normally happens during the first days of treatment. So, and because you will definitely see these patients back for checkups and repeat biochemistry, and so you will be able to identify the changes and adjust the dose as required. But it's very important that you have this in mind and you don't give azathioprine to a patient with liver disease, for example. So that would be a contraindication. As I was saying for cyclosporine, with azathioprine, we don't really have any guidelines. However, the ECVIM IMHA consensus statement recommends serum biochemistry and hematology every 2 weeks during the first 2 months of treatment, and then every 1 to 2 months until treatment is completed. And this is just because we want to monitor these patients for myelosuppression and also hepatotoxicity. I hope this makes sense. Next one is mycophenolate. I don't know whether you remember the slide on pharmacology. Mycophenolate and azathioprine work in a very similar way, so they should never be used together because they have the same pharmacological target. As it happened with azathioprine, mycophenolate itself is also just a prodrug. Okay, so on its own, it does nothing. It needs to be processed by an enzyme called GT, so the glucuronidase transferase, which will activate this drug. What happened? Here, once again, there is a bit of a controversy with cats. So some cats may have lower concentrations of this enzyme as well. However, we know that mycophenolate can be used in cats. It is safe to be used. There is not a lot published, but the case reports published, they do describe no side effects. So if we want to consider mycophenolate for a cat, that's fine. We can do it. We just need to use it with caution because they may not be able to activate this drug as well as a dog, for example. How do we use mycophenolate? So mycophenolate can be used both orally and IV. Orally is definitely the most common way to administer this drug, generally 10 mg per kg BID. Know that some, like BSAVR formulary, I think, and if you check other books, they go up to 20 mg per kg BID. At 20 mg per BID, I think maybe not all dogs, but most of them will have GI side effects. So a dose that we feel quite comfortable with is 10 mg per kg BID. You may need to adjust it down if side effects happen. Then onset of action can be very quick. So it's a drug that can be considered in an emergency setting. However, in some dogs, it will also take some days to weeks to actually work. So that's the problem with the second-line immunosuppressive agent, that we never know how fast they are working. That's the reason why we generally start steroids at the same time, because they work much quicker and we see better results initially. Then long-term is different, it's a different story. But the problem with all second-line immunosuppressive agents is that we actually don't know the onset of action so well. Mycophenolate can be used IV, and this is definitely a very, very good option in the emergency room. If we, or ICU, if we need to start these patients on something that we want to act very quick, then we consider IV mycophenolate. If you ever use IV mycophenolate, which is something that you may do, and what I find extremely difficult is actually the making up of the dilution itself, because it's very difficult. It comes in a very big box with a very long list of considerations and instructions. And every time I need to prepare or make up the dilution, I need to sit down and actually understand to make sure I don't mess anything up, because it's just very difficult. And the idea is that you need to dilute the powder that comes in the little vial with dextrose, 5%, until you get to a final concentration of 6 milligram per milliliter. You need to do something similar as well with the oral formulation with the liquid, because it also comes in a powder that settles very, very quickly. Therefore, it is very easy for the owners to be giving just the water that just remains on top and not giving any of the powder. So it's important that the bottle is well mixed before drug administration. So again, these are just minimal considerations, but they are somehow important, because we may see no results of the mycophenolate just because our dilution is made wrongly or because the owner is not mixing well the powder. So if you give it IV, another important thing is that it must be given over 2 or 3 hours to reduce the GI effects, nausea, but also to reduce risk of anaphylaxis and so on. When it comes to side effects, obviously it has also side effects, and there is a very nice study, relatively recent, of 131 dogs with immune-mediated disease that received mycophenolate. GI toxicity, once again, was the most common adverse effect. However, with dose reductions, the signs were self-limiting. But in some dogs, treatment had to be stopped just because the side effects were too severe. Then myelosuppression can happen, neutropenia, anemia, PLT. So these patients can develop pancytopenia due to the mycophenolate because of its action in the bone marrow. And some patients will also develop skin erosions or skin issues. And this is something that doesn't happen very often, but we recently had a little dog with immune-mediated thrombocytopenia that 2 days after receiving IV mycophenolate developed kind of very, very severe dermatitis around the eyes, periorbital dermatitis. And we really believe that was just due to the mycophenolate, and it's something that has been reported. In cats, as I said a minute ago, we can use mycophenolate. However, we have very, very limited experience for the safety and efficacy of this drug. So if you really need to use it with caution, because we don't know much about this drug in cats. I just put this here because I didn't want to forget, but if we are to consider omeprazole or esomeprazole when these dogs have GI toxicity, that you're unlikely to need it anyway, but if you were to give omeprazole, bear in mind that omeprazole will reduce GI absorption of mycophenolate. Okay, so you may need to consider another drug, or you may need to consider dose increase that you won't want to do because they don't have GI side effects. But anyway, it's important that you bear this in mind because it will definitely reduce absorption. When it comes to monitoring, as well as recommended by the consensus statement, in this case, they do recommend CBC every 2 to 3 weeks during the first months of treatment, and then 2 to 3 months until treatment is stopped. However, because we know little about mycophenolate, the strength of this recommendation is weak. And should we be more proactive, checking also liver values in these patients? We don't know. In dogs, we don't think it causes hepatotoxicity, but in people it does. So should we be more proactive? I guess we will find out when we see hepatotoxic when we see hepatotoxicity in these patients later on when we have more experience using this drug. And the last one you may be less familiar, as I am myself, with, because it's a relatively new drug, leflunomide. Again, leflunomide will affect DNA synthesis, will reduce DNA synthesis. It's a promising immunosuppressant, all right? It's something that we see it works very, very well to treat IMPA, even as a standalone agent without the steroids. It seems to lead into pretty good results, which is good. And you may want to consider in patients with these immune-mediated polyarthropathies that we all see. The dose is 2 mg per kg SIDPO. You can go up to 4 mg per kg, but it's generally not recommended. And once again, not recommended because we know little about these drugs. We don't know whether higher doses will cause more side effects. So a safe dose at this point is 2 mg per kg. And in cats, we generally, if you need to use it, we generally use 10 mg SID per cat, not per kilogram, just per cat. Leflunomide has also side effects. GI side effects have not been actually described in this. This is the only second-line immunosuppressive agent that doesn't seem to be causing many GI side effects, but mild diarrhea in only 3.3% of the cases. However, it seems to be causing random hemorrhage, which no one seems to be able to explain, lethargy, and it can also cause hepatotoxicity. All right, relatively mild, but it can definitely do. Therefore, the recommendation is that we do check serum biochemistry and hematology every 2 weeks for the first 2 months of treatment, and then every 1 to 2 months until treatment is stopped. Okay, as I said, all these recommendations are described in the IMHA consensus statement published in 2019. Once again, for this specific drug, because we don't know much about it, should we be more proactive? Should we be doing more? Should more monitoring? We don't know. We don't know. There could be some unrecognized side effects, but we should find out with time as well. And as a very general comment, what's very important with all these drugs is the safe handling. Use gloves, both you if you give it in the practice and the owners to do it at home. Some of these drugs are cytotoxic, myelosuppressive, so gloves are important. Tablets must not be crushed or split, okay? So, and that's a problem sometimes because it's difficult to adjust those to the patient size, but sadly they cannot be split. And this is very important. You tell the owner so they don't crush the tablets or anything. And then leflunomide should be used with caution in pregnancy. Obviously, avoid it in pregnant dogs or pregnant cats, but if the owner or whoever member of the staff is pregnant, should avoid contact with leflunomide because there are some reports that can cause some birth defects. So yeah, that's pretty much it. Okay, it was a lot to take in. I appreciate that. But just as a final summary, the key points of today's talk are here, summarized here. Immunosuppressive agents are common in practice these days. We use them quite a lot alongside the steroids, but also as a standalone treatment for some conditions. We should be using them with caution, because they can cause side effects and the owner must acknowledge the side effects. However, we should not be afraid of them because they can really improve the outcome and reduce side effect of steroids, which, as we discussed, can be quite severe, especially in large breed dogs. Although there are some guidelines out there, the treatment must be adjusted to the individual itself, all right? So don't just follow a guideline, don't just do what the formulary say, just you will need to adjust based on side effects and so, and obviously, if you need advice, feel free to contact the referral center. I'm sure everyone will be happy to help because we use these drugs maybe relatively more frequently than in general practice. But most of the things have very little evidence these days when it comes to second-line immunosuppressive agents. We should learn with time, as I just mentioned a few times. And the last one is that get familiar with them, use them if you feel it's indicated, because you may see better outcomes, less side effects. So I would encourage people to consider the use of these drugs. And I think that's me. I think that's the last one. Any questions, anything that people would like to discuss, feel free.
That's brilliant. Thanks so much, Javier. It's really good summary there, I think, of all the drugs. There aren't any questions at the moment, so I say if anybody's got any, if you just type them in the Q&A button, I'll put them to Javier. I was just wondering, just for myself, really, have you had, just generally, perhaps at Lumbria, do you get many advice calls from general practitioners about these drugs? If just to get an idea of how much they are being used in general practice.
Yeah, we certainly do, but to be fair, for example, with atopica, with cyclosporin, because it's something that general practitioners use quite a lot for skin. They are probably better than us using this drug itself. But when it comes to mycophenolate, when it comes to azathioprine, leflunomide, then yes, we do get quite a lot of advice calls, just because some people may not necessarily be very familiar with these new drugs, and fair enough. Sometimes we often have questions about these drugs because we don't use them. We use them quite a lot, but not as often as steroids, for example.
Yeah.
What we try to do, and any feedback is much appreciated, is when we send patients back to the referring practice after diagnosis of autoimmune diseases, we try to leave a relatively clear plan that can be followed. This sort of monitoring recommendations I've been describing, we normally include that on our report, so whoever takes over the case has a bit of an idea on how to best monitor these patients.
Yeah, great. Thanks, Javier. There is one comment. It just says clap, clap, clap. Thank you very much. So you must.
Thank you. It's a pleasure.
Brilliant. There's no other questions coming through there, Javier. So yes, we can perhaps enjoy the sunshine and leave it there for now. But thanks so much again for your time. Really nice to see you. And again, another really good talk. And I think we've got 2 really good webinars there now for everybody to watch back. And as I say, we've recorded this session, so we'll make it available on Knowledge Hub over the next few days so that you can go on and have a look back in your own time. Okay.
Excellent. That's brilliant. Thanks a lot again, and hope everyone has a lovely day. Bye-bye.
Cheers, Javier. Take care. Bye-bye.